Hello, everybody. It's a great pleasure for me to be with you today for a new webinar on fertility preservation. And today we will discuss fertility preservation in the adolescent girl. And we have the honor to have three speakers for this. The first will be Kirsten Trine-Macklon on the indication of fertility preservation in adolescent girls. The second topic and the second lecture will be done by Isabelle de Mistere on ovarian tissue cryopreservation versus oocyte vitrification, and then Michael von Wolf will close the session with the third lecture on the ethical issues. So we have a great hand of day today with these three lectures. So first, Kirsten, you can start with the first lecture on fertility preservation, the indication in the adolescent girl.
Thank you very much, Michael, and good afternoon, everybody. It's my great pleasure to be opening this second webinar in our series. And as Michael said, the first talk will be about indications. Now, first of all, let's try and see if I can do the next here. First of all, it's always good to define your population. So what's the definition of adolescence? Well, if you look at the Oxford English Dictionary, adolescence is defined as the period following the onset of puberty during which a young person develops from a child into an adult. It comes from Latin, adolescere, which means grow into maturity. Now, it's a period of changes. It's a period of dramatic physical, emotional, and psychological changes. So falling ill during this period demands a lot. It demands a lot from the patient herself. It demands a lot from the parents, the healthcare professionals, and other key persons. Also, it's a period where you see specific cancer diagnosis, which you don't see in the adult women. It's also a period where certain benign diseases will manifest themselves. And of course, it's a period of finding your sexual identity. So a very delicate period. This slide, we could stop here because here are the indications, or at least some of them, but of course I'll go into depth with some of them during this talk. But these are at least some of the major groups of diseases and diagnoses which could lead to fertility preservation. Cancer, of course, probably still the largest groups, but also anemias, autoimmune disease, renal disease, sclerosis. All of these, if severe enough, will require treatment with chemotherapy, typically as part of the preconditioning protocol before stem cell transplantation. And then you have the genetic conditions such as Turner syndrome or fragile X mutation carriers, and you have the whole group of individuals with gender dysphoria. So let's start by cancer. The reason why we offer fertility preservation to cancer patients, you're all probably very well aware of this. It's because we will give them chemotherapy, and we know that chemotherapy exerts varying degrees of gonadotoxicity. This is particularly the case for the alkylating agents. There are some examples here of the group of alkylating agents, drugs like cyclophosphamide, busulfan, cisplatin, ifosfamide. These are all gonadotoxic drugs. So if you have a young individual who will receive high doses of this, you should offer or at least consider offering fertility preservation. This figure here is from Wallace and Kelsey, a study where it very nicely, I think, illustrates what happens if you get chemotherapy. So down here on the x-axis, you have the age of the patient, and up on the y-axis, you have the number of non-growing follicles, or the number of primordial follicles. And as you're very well aware of, the girl is born with a finite number of follicles. So after birth, she's no longer able of creating new primordial follicles. So if, say, you have let's see if I can get my cursor here. If you have, say, a 15-year-old girl, she's got a lot of follicles, around about 250, 300,000, but then she gets cancer, she gets chemotherapy. She may not lose all her follicles, but all of a sudden, she may move down to the, see if I can get my cursor to work. There, she may move down to the green curve here, and this means that she will still have ovarian function, but she may have only 30,000 follicles left, and this will mean that her period of fertility will be shorter, and she will indeed enter menopause earlier than she would had she not had chemotherapy. Radiation therapy is also very detrimental to the ovaries. This causes lethal cell damage by double-strand DNA breaks. Radiation therapy works twofold, so it works both on the ovaries but also on the uterus. In the ovaries, it reduces the number of primordial follicles, and we know that doses down to just 2 gray reduces the ovarian reserve by 50%, and the sterilizing dose is 15 gray in an adolescent girl. If you radiate a girl before puberty, it's associated with smaller uterine volumes in adulthood. Now, often you won't irradiate a uterus because young girls don't get cervical cancer or colon cancer, but you use it as part of a preconditioning protocol if you want to do bone marrow transplantation as total body irradiation. If you radiate after puberty, it leads to a reduction in the uterine elasticity, impairment of vascularization, and inadequate placentation. And the sterilizing dose for adult women is more than 42 gray. It's a high dose, and yet this is what we give to women with cervical cancer or women with colorectal cancer. There are, of course, varying risks involved in the different treatment protocols. This is a figure we made adapted from these 3 references down here. Now, a high risk of ovarian failure is indeed seen in those who will receive bone marrow transplantation, but also young girls with CNS tumors who will receive the protocol called PCV, which stands for procarbazine, lomustine, and vincristine. And this protocol also includes alkylating agents. Then you have protocols with low risk, like first-line treatment for leukemia, or very low risk, like ABVD for Hodgkin's disease. So really, you need to look at the protocol before you counsel a young girl about fertility preservation. Cancer, indeed, is a disease of the elderly. Now, these figures are from the Nordic Association of Cancer Registries. Out here, you have the age, go up. Here you have the age of the patient, and you can see there's a peak in patients in their 70s and their 80s. Nevertheless, there are children and adolescents who are diagnosed with cancer. And what types of cancers do they get? Again, these figures are from the NordCan registries. Here you have the most common cancer types in females aged 10 to 19 years. And you can see the most prevalent cancer is brain cancer, followed by bone cancer, so sarcomas, and then followed by non-Hodgkin lymphoma, Hodgkin, and ALL. Now, if this was a younger age group, if this was very young children, the leukemias would move up. And if it were adult women, the most prevalent diagnosis you would see would be breast cancer and malignant melanoma. So indeed, this particular period has particular cancer diagnosis. Like I mentioned, there are also sometimes young girls with benign diagnosis whom you would offer fertility preservation. These are the patients with non-malignant diagnosis in our cohort in Denmark. And I've tried to put them into specific categories. You can see there's a wide variety of different conditions. You have the anemias, you have the autoimmune diseases, then you have the genetic conditions, renal diseases, benign gynecological diseases, and then you have a large group of various rare conditions. I will just go into detail with some of them. Aplastic anemia, it is a disease that most commonly, in fact, affects young adults aged 15 to 25 years. It's a rare condition in which the bone marrow is unable to produce enough blood cells for survival, and the treatment of severe cases is bone marrow transplantation. And if you remember the slide I showed, it has a high risk of ovarian failure. Other anemias, you have thalassemia, which is most often seen in countries around the Mediterranean Sea, India. It's an inherited blood disorder characterized by decreased hemoglobin production. Sickle cell anemia, which is prevalent in the sub-Saharan countries, is an inherited blood disorder characterized by abnormally shaped red blood cells caused by an abnormality in the hemoglobin protein. Both of these sometimes require bone marrow transplantation with an HLA-matched donor. Autoimmune diseases, I think the most common would be systemic lupus. This is a review that just came out this year where they looked at factors associated with fertility abnormalities in women. Down here in the table, you can see that they found 5 studies looking at premature ovarian failure or amenorrhea as outcome, as one of the outcomes. These women all received cyclophosphamide, either IV or orally. The ages varied from 18 to 50 years of age, but still, first study, 11 women out of 64 experienced premature ovarian failure. Other study, 11 out of 35, etc. They found that the factors associated with premature ovarian failure was higher age of the patient, higher dose of cyclophosphamide, and longer duration of treatment. So not surprising. Another autoimmune disease which you sometimes see, sometimes get referrals for these young girls, is autoimmune polyendocrine syndrome. It's an inherited autoimmune disease in which the immune system malfunctions and attacks the body's own tissues and organs. I found this recent study, which is a Finnish study, national cohort of 40 women diagnosed between 1965 and 2018. So you can see it's a rare disease because in a whole country, this long period, there was only 40 women. 29 of these women had a spontaneous menarche, but 28 out of the 40 developed POI at a median age of 16. And when they looked at those who did develop POI, they found that 93% of them had primary adrenocortical insufficiency and 81% had ovarian antibodies. Genetic causes, well, the most common, of course, is Turner syndrome. You know, Turner syndrome is the result of a partial or complete absence of one of the sex chromosomes. So a lot of these girls will be born with primordial follicles, but they will experience an accelerated loss of germ cells throughout childhood, Having said that, 33% of them have some pubertal development, and 10 to 15% experience some menstrual cycles. Spontaneous pregnancies are rare. They're seen in about 2.7 to 7.6%. And this is primarily within those who have mosaicism. So the question is, should we offer fertility preservation to young girls with Turner syndrome? A couple of years ago, a group of experts sat down. This is the international consensus group, including 55 experts from 16 different countries, discussing whether you should offer ovarian tissue cryopreservation to young Turner syndrome patients. Their conclusion was that OTC should be offered to young females with Turner syndrome, but under strict conditions only. And still, so far, there are no reports of cryopreserved ovarian tissue autotransplantation in women with Turner syndrome. There was a case report last year from Chapdelaine and Marie-Madeleine Dolmans from Belgium, where they described a case of monozygotic twins with Turner syndrome, where one of the twins experienced POI at the age of 16. The other did not. She had regular cycles, and she gave birth at the age of 33 and again at 35. And then when she was 36, she wanted to donate some of her fresh cortical tissue to her sister. So the sister received some fresh cortical tissue, and 4 months later, she started having spontaneous regular periods, and she became pregnant spontaneously and delivered a healthy girl. But this was tissue donated from her sister, who still had eggs. It was not tissue that was frozen. It was not her own tissue that was frozen when she was young. Then you have the group of individuals with gender dysphoria. I found these two studies. These are studies from Diane Chen from America. They made a survey where they wanted to know about the knowledge of fertility preservation in healthcare professionals caring for transgender, pediatric, and adult individuals. And they found that there was a high overall fertility-related knowledge. So at least the centers they asked were very much aware of the fact that it might be a good idea to discuss fertility preservation with this group of individuals. Nevertheless, only 13 out of 105 transgender adolescents sought fertility preservation before initiating hormones. And 7 of these were transgender men. And of these, only 1 opted for oocyte vitrification. And when they asked the adolescents themselves why they didn't want to go further with fertility preservation, they said that one of the reasons was the costs involved. So this is a study from America where often you have to pay yourself. There's not, they don't have socialized medicine, but also the invasiveness of the procedure. So they did not feel comfortable undergoing hormonal stimulation and transvaginal scans and oocyte pickup. And they did not want to delay the medical transition. So the wish and desire to go through the medical transition was higher than the wish to save oocytes. So finally, to conclude, fertility preservation should be considered in adolescents with cancer before chemo or radiation therapy, depending on the protocol. It should also be considered in patients with benign conditions, particularly where BMT is planned or treatment with high-dose alkylating agents. Fertility preservation could be offered to Turner patients in selected cases, although still experimental. And fertility preservation should be discussed with adolescent transgender men, but compliance is low. So thank you very much for your attention, and I am happy to take your questions. Thank you.
Thank you very much, Kirsten, for the great talk. So it's now time for a question. I don't know if there are some questions. Just have to wait perhaps 1 second. Okay, no question at the moment. So go for a couple of questions from myself and perhaps Michael and Isabel, if they're. Regarding the indication, do you think that there is an age limit for, in general, for this, or is it we have to discuss adolescent, but what do you think is the best?
Well, I can tell you my personal experience. We don't have a lower age limit, because sometimes you have very, very young patients who still need fertility preservation. So I think the youngest patient in our cohort was just 6 months old. You know, sometimes with the neuroblastomas, for instance, these patients are quite young, 2 years old, 3 years old, I think you need to have a clear indication. So you shouldn't do it for first-line chemotherapy for ALL, for instance, or other things. But if you have a very clear indication, then I think that if you have pediatric surgeons who are comfortable with doing laparoscopy on small children, then I think you should have it. Upper age limits, it's of course that's biological, isn't it? If there aren't any follicles left, or only a few, then it doesn't make sense to offer fertility preservation. We offer it up to 40 years of age at our clinic. But in the adolescents, I think what you also want to ask is often it won't be necessary, because they have, luckily they have a high ovarian reserve. So maybe your limit is to when you will offer fertility preservation is higher than for the 35-year-old woman, of course. So I can only say you have to make an individual assessment in each case. Okay,
there is a question regarding this age. And do you consider the anesthetic risk for this patient if you do not want to offer something before the age of 1 year? Or
well, you have to of course make sure that you have a pediatric department and an operating theater and staff that are comfortable and experienced with this very young age group, because this is a specialized treatment, isn't it? And so you need to be working with the colleagues who are experienced in treating these very, very young patients. Often these patients will undergo anesthesia anyway for other things, like they have to put in a line or other things. And then in the same anesthesia, you could do the laparoscopy and remove the ovary.
Okay, and what about the patient you've discussed Turner syndrome, but there are other diseases more or less which are more or less the same in terms of ovarian function, like galactosemia, which might be possibly worse in terms of oocyte depletion.
Yeah.
So do you think this could be an indication? And what about the genetic risk regarding transmission? It would be probably discussed with Michael.
Yeah, it is indeed one of those gray zone areas, isn't it? The girl I told you about, who was 6 months old, she indeed had galactosemia, and often they run out of eggs at a very early age, don't they? Then you have the question about what's their mental capacity when they become adults. Now, some will function very well, but there will be patients also who won't function very well. So are they at all suited for parenthood? But yeah, this is a whole ethical discussion, isn't it? And maybe Michael would touch upon it later.
Yeah. Okay, just a reminder to the audience that you have to use the Slido for asking question. We're waiting for you and for your questions, not only for Kirsten but also for the two other lectures. I don't know, Michael or Isabel, if you have questions regarding the indication in the adolescent population. Or perhaps they do not.
Perhaps the time is up, isn't it?
Well, we have 4 more minutes.
Okay.
If we want.
I just have the question because you mentioned the non-oncological indication, which is even sometimes more challenging than the oncological indication in this young population. And what is your policy in the management of this patient? Do you try to wait more when there is no immediate risk of premature ovarian failure because they are adolescents and you would like to reach adults before offering an invasive procedure, whatever it is, or do you consider them as if they were adults?
No, I don't consider them as if they were adults, but if they're about to receive a preconditioning protocol with high-dose alkylating agents, then I do offer them ovarian tissue cryopreservation. If they have lupus, for instance, or some renal disease, glomerulonephritis, and they're going to receive cyclophosphamide, but in not that high doses, then I will wait and see. And I mean, you can always say to the patient, well, listen, you're welcome to come back 1 year from now, or 2 years from now. But I wouldn't do anything invasive if her risk of ovarian failure was low. I wouldn't. And sometimes sometimes we get patients referred who were treated as adolescents, then they got healthy again, and then at the age of 25 they're worried about their fertility, and then they come up to us and we do a fertility assessment, and if they then have a low or somewhat low ovarian reserve and they're not ready to become mothers, then you could offer oocyte vitrification in that case.
Okay, Kirsten, we have just one question, which will be the last one for your session. There is another one just coming. So, do you consider the ovarian pathology as an indication, benign diseases, gynecologic disease, ovarian diseases, such as dermoid cyst,